Reproduction Part 2. The nurse has to be up to date on current contraceptive practices and be comfortable discussing contraception methods with women and their partners. The nurse also has to be sensitive to the woman's feelings and concerns and not introduce their own personal biases. The nurse needs to help clients choose an appropriate method of contraception. And nurses have to understand that contraception does not always prevent pregnancy. Perimenopausal women, once again, as I discussed in the first lecture, may continue to ovulate as long as they have regular menstrual periods. And some even ovulate when indications of menopause are present, so contraception is also very important for these women. We need to look specifically at adolescence and contraception. We may not particularly approve of adolescence and contraception together, but at the same time, we have a duty to make sure that they are educated appropriately. They tend to get their information from their peers, and those peers often pass along incorrect information. And adolescents are also likely to use ineffective or inconsistent contraceptive methods. They go with the mentality is, it's not going to happen to me, or it's just one time, etc. We, again, cannot introduce our personal biases, but we have to treat the adolescent with the respect and dignity that we would any other patient. Understand that the adolescent knowledge level, again, may have misformed or misinterpret information. They also have inconsistent knowledge levels. When we're counseling, again, we need to be sensitive to feelings, concerns, and needs and be non-judgmental. Anxiety or concern as the adolescent must admit that they are and or plan to be sexually active can be very stressful for adolescents, and they may not seek information from appropriate sources because of this. And again, we have to accept the adolescent regardless. A behavior of adolescence that affects contraception, again, is the risk-taking behavior. Often they don't plan sexual intercourse, and they're not prepared with contraceptives. The most common methods that adolescents use are oral contraceptives and condoms. And due to a lack of compliance or consistency, we might think about recommending a vaginal ring or the patch because it might be more effective with these adolescent girls. Nurses should always encourage the use of condoms in sexually active adolescents to help prevent STIs, even when they are using another type of contraceptive method. There's several different contraceptive methods out there, and you need to be familiar with as many as possible, if not all of them. Natural family planning is also called periodic abstinence method or fertility awareness. It uses physiological cues to predict ovulation, and they avoid coitus or sexual intercourse when the condition is favorable for fertilization. For example, we look at body temperature, vaginal secretions, the calendar, or the rhythm method. This can also be used for women who are wanting to become pregnant. We need to provide education that these methods are definitely not 100% effective. Intercourse occurring during the fertile time can result in pregnancy. Abstinence is the avoidance of sexual intercourse and any activity that may allow sperm to enter the vagina. It is the only completely effective method of preventing pregnancy and STDs. Even sperm in the outer area of the vaginal vault can travel all the way up to the ovum and fertilize an egg if she is fertile at that time. So again, any type of activity that can allow sperm to enter the vagina can be considered risk for pregnancy. Barrier methods will include providing education and demonstration of how to appropriately apply the device. Spermicides are chemical barriers, and they should be in contact with the cervix at least 15 minutes prior to, but no longer than 1 hour before sexual intercourse, and they must be reapplied prior to additional intercourse. The typical failure rate of spermicides is 29%. The male condom, which is the only male contraceptive available, is another barrier device, but there is also a female condom, which is called a vaginal pouch, and it's a polyurethane sheath that is inserted into the vagina. Male condoms have to be discarded following each use, and there is a risk of hypersensitivity with latex condoms. The typical failure rate of the male condom is 15%. Female condoms are also intended for one use only, and they should not be used concurrently with male condoms because there's an increased risk of tearing. The typical failure rate of the female condom is 21%. The sponge is made of a soft polyurethane that traps and absorbs semen and also contains a spermicide. It provides contraception for 24 hours. It does have to be wet with water prior to being inserted, and it can be used for repeated intercourse within that 24 hours as long as it has not been removed. It should be left in place for at least 6 hours following intercourse. The typical failure rate is 32% in parous women and 16% in nulliparous women. The cervical cap, fem cap, and the diaphragm. The cap is smaller, and all of these have to be fitted by the healthcare provider. They're flexible silicone caps that are inserted over the cervix after placing spermicide on both sides. It will stay in place by suction, and it can remain in place for 48 hours. And like the sponge, should not be removed for 6 hours after the last intercourse. Should not be used during menses. The typical failure rate of the diaphragm is 16%, and the typical failure rate of the cervical cap is 16% in the nulliparous women and 32% in the multiparous woman. The risk of toxic shock syndrome, again, can occur in association with the use of diaphragms, cervical caps, and sponges. Breastfeeding is also a contraceptive method. It can provide some protection and actually can provide very good protection with feeding patterns that have intervals less than every 4 hours and no more than 6 hours at night, and no infant supplementation, although your book will state 10 times in 24 hours. Excuse me. The highest success rates include not disrupting this pattern or providing any supplementation, and if that is followed, the typical failure rate is 2%. Unreliable contraception includes the withdrawal method, douching, and breastfeeding if it is not done according to the guidelines that I just provided. Hormone injections. Depo-Provera is a progestin injection that prevents ovulation for 14 weeks. Injections should be every 12 weeks. Excuse me. Can cause amenorrhea, breakthrough bleeding, weight gain of about 14 pounds in 4 years, headaches, depression, hair loss, decreased libido, and breast discomfort. It should be given through a deep intramuscular injection, and the site should not be massaged because it will accelerate the absorption and decrease the period of effectiveness. Typical failure rate of Depo-Provera is 3%. Backup contraception is necessary after the first injection unless menstruation begins within 5 days after the injection. Implants will provide contraception for 3 years, and it's implanted under the skin of the upper non-dominant arm. It's removed with a local anesthetic, and there is a prompt return to fertility once it's removed. Oral contraceptives decrease there is a decrease of long-term side effects, but women who have thromboembolic conditions, cardiovascular disorders, long-standing diabetes, migraine, headaches that have the aura, neurologic symptoms, stroke, and breast or liver cancer should not use oral contraceptives. Common side effects will include nausea, breast tenderness, and fluid retention. And there's some interactions with other drugs, such as anticonvulsants, systemic antifungals, anti-tuberculosis drugs, and anti-HIV protease inhibitors. They all reduce the effectiveness of the oral contraceptive. The typical failure rate due to omission is 8%, but it is almost 100% if it's taken correctly. Again, one lifestyle habit that will increase the risk of complications when a woman takes oral contraceptives is smoking. Transdermal may be more effective than oral contraceptives because it's only used once a week as opposed to on a daily basis. The patch is applied to the abdomen, the upper torso, the buttock, or the upper outer arm. The site should be rotated weekly, and it should be applied to clean, dry skin the same day of the week for 3 weeks, with the 4th week being patch-free. The mechanism of action, efficacy, contraindication, skin reactions, and side effects are similar to other hormonal contraceptives. The typical failure rate of the transdermal patch is 8%. The vaginal ring is inserted into the vagina, and it's left in place for 3 weeks, and then it's removed at the end of the 3rd week. It releases estrogen and progestin. A new ring is inserted 1 week after the removal of the old ring. Backup contraception is necessary for the first 7 days of the first cycle. Its main side effect is a headache. The vaginal ring does not have to be fitted, and it can be removed for up to 3 hours at a time without losing any of the effectiveness. The mechanism of action, efficacy, contraindications, skin reactions, and side effects, again, are similar to other hormonal contraceptives. The typical failure rate of the vaginal ring is less than 8%. Intrauterine devices, or IUDs, are inserted into the uterus to provide a continuous pregnancy prevention by the healthcare provider. Some devices will contain a reservoir of progestin or other hormones. Some are replaced every 5 years, and others are replaced every 10 years. Side effects can include cramping and bleeding, menorrhagia, dysmenorrhea, and complications will include perforation of the uterus at the time of insertion, ectopic pregnancies, spontaneous abortions, and preterm births. The client should monitor for a tail hanging into the vagina, expulsion of the IUD, and signs and symptoms of infection or pregnancy. The typical failure rate is less than 1%. And then there's the morning after pill, which prevents pregnancy after unprotected sexual intercourse or if a contraceptive method fails. In other words, a male condom breaks, as an example. Complications of birth control pills. This chart is something that you should become very familiar with as a nurse and an educator, because we all know that people sometimes inadvertently forget to take one of their oral contraceptive pills. And this tells you what to do if a pill is missed or more than one pill is missed. Sterilization is a type of contraception that is almost 100% effective. Some sterilization procedures can be reversible, but it is very expensive. Bilateral tubal ligation is widely used. It will cut or occlude the fallopian tubes. Education to women after surgery should be to refrain from intercourse, strenuous exercise, and lifting heavy objects for at least 1 week. Half of tubal ligations are performed immediately after a pregnancy. The procedure may be completed by electrocoagulation and ligation, which are permanent, or bands and clips, which may possibly be removed or return potential tubal patency. The healthcare provider should be notified in cases of fever, fainting, severe pain, or bleeding or discharge from the incision. Transcervical sterilization is still considered to be experimental. They inject occlusion agents into the uterine tubes, and this can be done without anesthesia, but it may require some analgesia. It is more convenient for obese women and those with adhesions. It can take up to 3 months for occlusion to occur, and it should be confirmed before relying on it as a sterilization method. Complications will include expulsion and perforation. The typical failure rate is 1%, but because it's still considered experimental, the long-term efficacy is unknown. Hysteroscopic sterilization is done with saline distending the uterus and a microinsert placed into the fallopian tubes. Inflammation will occur and it will result in permanent closure within 3 months. And vasectomy, which is a small incision or puncture made in the male scrotum to cut, tie, cauterize, or remove a section of the vas deferens which carries the sperm. We recommend rest for 48 hours with ice application to the area and the wearing of scrotal support. We also recommend no strenuous activity for a week, and the client should call the healthcare provider in instances of fever, severe pain, bleeding, or discharge at the site, swelling greater than twice the normal size, or a painful nodule. We also have to be familiar with abortion. Although abortion is the appropriate term for a miscarriage, in this instance we're talking about abortion being the intentional cessation of a pregnancy. We have to be able to provide appropriate client education prior to the procedure so all women are adequately informed of all their choices. Education should include appropriate education of the procedures that she is considering, including the side effects and the risks. Nurses should also know state laws prior to any counseling or care to women choosing abortion. Induced abortion is the purposeful interruption of a pregnancy before 20 weeks gestation. It's one of the most controversial and emotional components of health care. There are regulations existing that protect the mother from complications, and many states will enforce a mandatory delay or state-directed counseling. In second trimester abortions, it is a state regulation as to the procedures. Third trimester abortions are limited and/or prohibited by state regulations. Elective abortions are performed at the woman's request, and therapeutic abortions are performed for reasons of maternal or fetal health or disease. And we're looking at the preservation of life for the health of the mother. We're looking at potential genetic disorders of the fetus, or in the cases of rape or incest. With a first trimester abortion, aspiration is the most common procedure. It's done at a local office, clinic, or hospital. A speculum is inserted into the vagina and the cervix is anesthetized and dilated. A suction catheter is inserted and the products of conception are evacuated. The woman will experience some cramping and bleeding, just like a heavy menstrual flow. Complications can include excessive bleeding and infection, and prophylactic antibiotics may be administered. NSAIDs are usually recommended for any discomfort. A medical abortion is done with different drugs, methotrexate, misoprostol or Cytotec, and mifepristone are the drugs that are used to induce an early abortion. Methotrexate is given IM or PO. Misoprostol is given PO or vaginally, and mifepristone is given PO. We expect to see vaginal bleeding and uterine cramping, and side effects include nausea, vomiting, diarrhea, headache, dizziness, fever, and chills. Second trimester abortions are associated with more complications. It's usually done by a dilatation and evacuation, and it can be performed up to 20 weeks gestation. Cervical dilation is required and larger instruments are necessary to remove the fetus and the placenta. There are possible long-term harmful effects to the cervix in these procedures. The second trimester abortion can also be done by injecting hypertonic solutions directly into the uterus to induce abortion. Infertility is the inability to conceive after 1 year of unprotected regular sexual intercourse. The practice of infertility health care also includes those couples who conceive but repeatedly lose a pregnancy before the fetus is old enough to survive. Primary infertility is defined as never having been pregnant, and secondary infertility is defined as conceiving but unable to conceive again. We have to look at several different things when we're evaluating infertility. We start by looking at preconception counseling that may assist in understanding the importance of an adequate diet and the need to avoid teratogens, which are substances that can cause harm to the fetus, especially or at any time during the pregnancy, but especially during the first trimester. We look at their reproductive history. What is their menstrual pattern? When did they start? How frequent are their periods? The amount of flow, presence of pain, regularity, etc. Any other pregnancies with complications or outcomes? What contraceptive methods did they use? Pattern of fertility of intercourse? Length of time the couple has had intercourse without the use of contraceptives? Any exposure to toxins? A family history of multiple pregnancy losses or birth defects? Past surgeries? Pelvic inflammatory disease? Sexually transmitted infections, or abnormal pap smears. A physical examination is done on each partner to assist in identifying diagnostic testing that might be helpful in determining what can be done for this couple. A chromosomal analysis or maternal blood clotting studies can also be done for repeated pregnancy loss. Diagnostic testing will begin with the least invasive, least expensive test first that has been indicated to diagnose the issues from the above physical examination. Many simple evaluations are done simultaneously, while some more complex tests might be delayed until a need has been established. There are several different therapies that may facilitate pregnancy. Medications such as hormones, as well as other medications, may be given to either the man or the woman to improve semen quality, induce ovulation, prepare the uterine endometrium, or support the pregnancy once it is established. correct infections or endometriosis, or assist with erectile dysfunction. Different hormones can be ovulation-inducing medications. Ovulation induction can increase the risk of multiple births because several ova may be released and fertilized. Surgical procedures such as endoscopic procedures to correct any adhesions or obstructions, or laparotomy to relieve pelvis inflammation. Therapeutic insemination can use either the partner's semen or that of a donor to overcome a low sperm count. And a donor is used if the woman's partner carries a genetic defect or the woman wants a biological child without having a relationship with a male partner. Egg donation may be an option for women who do not produce ova because of premature ovarian failure or who do not respond to ovarian stimulation. Same risks as sperm donation include the risk of infection for the one receiving the donation. And then you also have surrogate parenting, which could be in the picture if a woman is infertile or unable to carry a fetus to a live birth. The surrogate can supply the uterus only, and the couple's sperm and ovum are used, or the surrogate can be inseminated with the male partner's sperm. Unfortunately, this can cause custody issues in some cases. ART procedures are available to bypass physical obstacles to conception by placing gametes together to promote fertilization. There are several different procedures. In vitro fertilization may be done to bypass blocked or absent fallopian tubes or unexplained male infertility. Fertilization will occur in a lab, and then the fertilized oocytes are returned to the uterus. There is the risk of more than one ovum implanting, with twins being the most common. Women are given supplemental progesterone to promote implantation. Gamete intrafallopian transfer. A woman must have one patent fallopian tube for a surgical procedure. There is a removal of ova from the ovary and sperm, and one or two ova are injected into each fallopian tube through a laparoscope. Supplemental progesterone is also given in this procedure. Zygote intrafallopian transfer is also known as a tubal embryo transfer, where the ova are fertilized outside a woman's body and fertilized ova placed in a fallopian tube. A woman must have at least one patent fallopian tube. Intracytoplasmic sperm injection is a percutaneous or microsurgical sperm aspiration, where the sperm is then used to fertilize ova by intracytoplasmic sperm injection. There may be the removal of a single spermatozoon from the testes with a small gauge needle. Peri-implantation genetic testing allows informed decision making. It's specific genetic testing that is performed on the fertilized ova, but the healthcare team cannot rule out everything. People seek help for pregnancies for various reasons, and we have to explore these reasons. We need to identify the importance of this couple having a baby. Each partner might place a different priority on having a baby, and these partners have to resolve in the manner in which they resolve these issues is crucial to the stability of their relationship. They may feel as if one partner has a disinterest if they're not ready to have a baby. These couples have to be willing to share intimate information about their sexual relationship, such as frequency and timing of intercourse, before they begin to seek assistance with infertility. Financial concerns about the cost of treatment oftentimes will affect a couple's decision to seek treatment. Many infertility treatments are expensive, and the couple may not be able to afford them. Both partners have to be committed to the infertility treatment, as it can take years. It can take a toll on the couple emotionally, physically, and financially. The diagnosis of infertility can shake positive self-image the couple once had. So we start with assessment. What point are they in their fertility treatment? We have to look at their relationship. Has being infertile caused the couple's has it affected the couple's relationship? How has it affected it, and how are they adjusting to it? Do they have a support system, and who is their support system? And that support person can be different for each person of the relationship. Does their religion or culture view infertility in a negative or positive way? Are any of the treatments or therapies unacceptable to one or both of the partners? And how is the couple coping with the infertility in terms of time, money, and discomfort? So, a common diagnosis for a couple with infertility might be situational low self-esteem related to loss of control, and deficient knowledge related to the new condition or treatment.